Hi, everyone. Thanks for being here.
Good morning.
Good morning. I am not at my best, even though I do look amazing. No, and so my colleague Lisa will be facilitating after I sort of kick us off. I'm sorry, but I'm here to give energy. And,
Well, we appreciate that.
and I'll be monitoring the chat and I'll be making everyone feel welcome and excited. So I will be doing that even though I have little voice. We should be getting started here in about 4. Do we have Melissa Moorhead here? She's got to come. Claire, will you tell her? Ah, yes. Hi. Hi, Renee. Hi. Okay.
Hi.
We're ready. Hi, Marissa. We have,
Hello.
I think 175 people wanted to be with us today. It's just so awesome. Usually some people can't make it, but we will be sending out the recording and the slides as we do. We'll get started here in 2 minutes, and you won't have to listen to me much longer.
Hello? You're not feeling well?
Melissa, hi.
Hi. Hello?
Hi. Yes, we can hear you. You are here.
I tested the wrong system earlier, but
we can hear you and see you, which is amazing. There's Teresa. Oh my God, it's all happening.
All right. And no echo?
No echo. Oi, Katie, those ding dongs. It's my fault. You tell me every time. Can't figure it out. Okay. Hi, it's 10 o'clock and we have a lot of important people and so much important things to talk about. And this stuff that I do is the least important. So I'm going to start right now. Thank you for coming to the download. This is MiHIN's monthly webinar diving into the intersection of healthcare and technology. I so appreciate you taking the time to come here. I see a lot of people that make it every month and you guys are the best and keep coming. We're really trying to get to what you guys care about. We're really trying to get to the right panelists. We're really trying to make this the room where it happens. So thanks for coming. Next slide, please. A little bit about MiHIN before we start. MiHIN is Michigan's nonprofit statewide shared digital infrastructure. We were created to solve for these silos in healthcare. We were created to connect disparate organizations, disparate care teams, disparate entities in sharing health information that makes it possible to care for people better. We are a neutral steward of data. We do not produce our own data. We don't compete with providers in the marketplace. And most important to me and to our discussions today, and when you're with me, I'm going to focus on the human infrastructure that makes MiHIN possible, that makes our cooperative network possible. There is a lot of technology, a lot of pipes, a lot of data, a lot of stuff happening that is super important. And I don't understand most of it. What I understand and what's most important to me during these conversations is the human infrastructure. Technology is the tool and humans are the energy, and technology shall serve humanity and not the other way around. We are trying to support the human ability to connect, to learn, to decision make at the right time using appropriate context, to communicate and to collaborate. And that doesn't just happen with technology. It happens with people coming together, agreeing to work together, and the work happens at the speed of trust. That's the hardest part. And I'm thrilled to be here with you. Thank you. That was the welcome. I sound terrible, and I'm going to hand it over to our partner, Dara at HIMSS, because today's agenda, today's download supports the HIMSS Global Health Equity Week that is happening next year. Dara, please tell us a little bit about what HIMSS is, what Global Health Equity Week is for, and then we are going to jump into our important panel. Thank you so much. Also, guys, I'm a big believer in the chat. The chat is where it's at, especially when I sound like this. Let's get your questions going. I interrupt a lot and people don't like it. But if you feel like you need to interrupt, I understand and we will forgive you. Thanks, Dara.
No problem. Absolutely. And it looks like my slides are going to be shared. All right, perfect. So yes, thank you so much for having me this morning. I am always happy to talk about HIMSS and what we do on a local, state, and national and international level. My name is Dara Barrera. I serve currently as the immediate past president of our Michigan chapter of HIMSS. I have been a board member since roughly 2014. And my day job is I am the manager for practice management and health information technology with the Michigan State Medical Society. So I know I see a lot of you in multiple different ways that I work across the state. So it's always good to see so many familiar faces. Next slide, please. So Global Health Equity Week is coming up next week. And this is HIMSS opportunity to help everyone across the globe really take action to advance health and wellness. You will be seeing as we talk that there are virtual marches, virtual meetups, webinars, events that are planned for next week that are available to everyone, spanning a number of topics. It is to advocate to support healthy communities. It is to help people share their stories. You can see that there is a new hashtag, health equity. So if you have a great health equity story and you are putting it out on social media, use the hashtag so that you can keep track and be sharing those stories with everyone across the globe. The website to learn everything, because I'm just giving high level today, is right there, yourhims.org/GHEW Global Health Equity Week. Next slide, please. So how did this start? We all have heard of, if you're in the health HIT world at all, of National Health IT Week. That has been going on for a number of years and across the country and really across the world. This transitioned into health equity as we started to narrow our focus on certain topics about how to help educate and spread the word about closing those gaps in equity. And topics over the past years have been maternal health, patient identification, telehealth, I mean, all things that are absolutely still happening today, broadband access, public health data and modernization. But as Joanne said, it is how this technology is used in order to be able to help the patients where they are to get what they need. Next slide, please. So what is health equity? HIMSS definition is that this critical need is to give equal access to health and wellness services regardless of the patient's geographic location, ethnicity, socioeconomic status, gender, and other demographic factors. So things that we hear across all of our meetings currently, SDOH is definitely a buzzword. You're hearing that everywhere. It's where a bulk of the work is happening. And so that is how we are helping with health equity considerations and factor disparities into access. So not just is a patient getting their prescription filled, which is what a lot of people think HIT is doing. It is, are these patients needing access to food? How do we find out about that? How is that being shared with practitioners? If they're going to a food bank, how is that information getting back? Health equity is making sure that that patient is getting what they need, regardless of where they are and regardless of what that need is. Next slide. As we say, this is global. So according to the World Health Organization, which surprisingly enough, and before the last 2 years, a lot of people didn't even know who the WHO was, but now we hear their name regularly on the news. But inequity is the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Health inequities therefore involve more than inequality, which I think gets mixed up a lot. Equity and inequality are two different words and mean kind of different things with respect to health determinants and the access to the resources that are needed to improve and maintain health or health outcomes. So that kind of changes it a bit when you think about inequality versus equity and what do those two mean. And then next slide, you'll see kind of how HIT is driving a little bit of that. So really, what is health equity when you're looking at diversity, equity, and inclusion? It is the equitable access to health and wellness services regardless of where the patient is, regardless of their socioeconomic status, gender, demographic factors, how they identify, whatever that may be. It is the insurance that that patient is getting what they need. How healthcare and HIT are really looking at this, there is a lot of workforce development and advancement because as Joanne said, it is the people that drive this, but the people can't do this unless they know what's needed, and that comes from information. Disparities in patient ID and access. Obviously through COVID-19, a lot of this was really put under a microscope. And so how cases are being worked now versus a couple of years ago are really changing. And communities and healthcare organizations are really exploring ways to ensure inclusion. You're hearing these words on a regular basis now, where it used to just be once in a while in a presentation that someone was talking about the future. This is what's being done now, and looking at how it can be affected now. Next slide, please. So 2022 Health Equity Week topics. This year, they're talking a lot about chronic disease management, digital health literacy, inclusion and access, maternal health, once again, substance use and behavioral health, and workforce inclusion. So topics that are really, spanning a number of areas from, the clinical to the technology to the human resource and people. You will be able to register for webinars, for networking meetups, for multiple different types of events next week. And I believe on my next slide, I have kind of a highlight of what the calendar. Yep, so here is the link, and I believe you're sending these out, so it can be a shortcut for people. The link to be able to register and see the full calendar of events, but things such as rural informatics, something that we have a lot of need for in the state of Michigan, obviously. Chronic disease management, always a focus, but this one is focused on empowering the Latinx community. Women in health IT, always love talking about women in HIT. It's a virtual meetup. Moving beyond screening, effectively meeting patients' social determinants of health needs. LGBTQIA+ community connections, and supporting healthy communities, global perspectives on equity and digital health. So you can see just this taste is a lot of different topics in different mediums. And so it's kind of something for everyone. You'll also find on this page a number of recorded webinars, articles, use cases, a lot of different information, things that if you want to be able to share in your own social media or look at your own information, it's there for you as well. So I would be remiss if I did not touch on our Michigan chapter. As I said, I've been a member of the chapter for a number of years, and we have roughly 1,700 members. These were last month's members, and I know we've added some since then. We have organizational affiliates, physicians, clinicians, nurses, vendors, people in health IT, you name it, across our membership. We work on innovation and policy. We have been very active in helping to create the new state HIT roadmap. We do a lot of advocacy on the local, state, and national level. And so next slide, please.
Everybody will be getting these slides. We always ask, we will be giving all of this information. So they will be able to have it in their hands.
And so just a brief, I always love to give credit because we are all volunteers. These are not our day jobs. So these are things that we do, as board members outside of what we do every day. So here is our executive board. There may be a few familiar faces there as well. Next slide, please. We are very blessed to have such good board members, from consultants to MiHIN staff, few good people here as well, to people who work with the payers, Helen Hill, who you all obviously know. So this is the rest of our board outside of the executive committee. And then next slide. We always have opportunity for volunteers to join our work groups. So program memberships, advocacy, sponsorship, different things. So if anyone is looking to become a part of our HIMSS board as a volunteer, we are always looking and we have those opportunities. So you can please reach out and let us know. But so here are some of our wonderful volunteers. And next slide. So for more information, you can go to our Michigan HIMSS chapter website. Our current president, Lee Marana, who is in the UP, was not available today. And so I am the immediate past president. But so you can reach out to any of us. And I know there's gonna be a lot more information, but next week will be jam-packed. And I know I have a ton of webinars on my schedule already, and there will be more. So keep track of our website and the national website for more information. And that's it, Joanne, unless there's any questions.
Thanks so much, Sarah, for being here. You will get your information about HIMSS, and thank you for all of the work that you guys are doing to support health equity. We're going to get into it now. Health equity. We will be using HIMSS's definition of health equity for this conversation. Katie, if we can put those slides back up, I'm going to do a quick introduction so we can really get to the heart of this. Oh, is everybody seeing a screen? I'm not seeing it either. All right. What's data? Guys, what does data have to do with health equity? We've got a lot of people that are working overtime on what's data got to do with health equity. I am pleased to introduce Lisa Nicolau, the director of our cross-sector data sharing team at MiHIN. We were formally named social determinants of health. And like many of you and like many of us here, we acknowledge that MiHIN was not going to be able to solve for social determinants of health. Instead, we had to focus on what we can do, which is looking at cross-sector data sharing. Lisa, I'm going to turn it over to you to introduce our panelists. And then the panelists are going to take their time. As you introduce them, I think the panelists should take their time to talk about what they do at the intersection of health equity and data, health equity and technology here in Michigan. Thanks so much.
Great, thank you so much. And yes, focusing in on that idea of cross-sector data sharing to make sure that we can get the data where it needs to be, to whom it needs to be to, in a legal and technically succinct way. So I don't want to spend any more time on MiHIN. I want to turn this time over to our panelists. I'm going to start with Teresa Anderson, the Senior Data Strategy and Implementation Advisor with the Office of Policy and Planning. Teresa, go ahead and unmic and have at it.
Good morning, everyone. I'm very excited to be part of this panel today. And I feel like I have the longest, I'm looking at the title, I have the longest title, but basically what I do, the work that I'm doing is related to our HIT roadmap, working with our HIT Commission and connecting the dots between work that the state already has started, work that MiHIN has already started, leveraging some of the infrastructure and interfaces that we currently have, and then just making that visible via our tracking of the HIT roadmap. So I'm excited to be on this panel to talk about how health equity and our work is having an impact in the state as of today and in the future. So thank you.
Fabulous. Thanks, Teresa. Next up is Marisa Ebersol-Wood. She's the Vice President of Regulatory Implementation and Data Governance with Blue Cross Blue Shield. But today she is representing the HIT Commission as well as the newly developed CIE Task Force. Marisa.
Thank you. It is a pleasure to be here with you all today. I kind of have a couple different hats, right? As you mentioned, I'm at Blue Cross. And part of my role at Blue Cross is regulatory implementation. So I've had the honor of leading our implementation around interoperability. And initially that started right with the member-focused components, but it is going to shift and move into some of these elements as well. So I have a very distinct interest in how interoperability is going to work as it relates to community information, social determinants, et cetera. And so that's kind of my business hat. But then also I have the honor of being on the Health Information Technology Commission and supporting the roadmap efforts there. And as a part of that, joined the committee around community information exchange specifically to support the right voices kind of coming to the table and informing what we're trying to do with the overall roadmap. And I think you'll hear a lot more about that from Teresa and Molly a little bit later.
Fabulous. Thank you so much. Next up, we've got Melissa Moorhead. She's the program manager with DASH. If you haven't heard of DASH, it's Data Across Sectors for Health. Melissa, go ahead.
Nope, Melissa.
Thank you very much.
Yes.
Negotiating too many screens. Data Across Sectors for Health is a program office of the Robert Wood Johnson Foundation. And for the last 6 or 7 years, Michigan and Illinois public health institutes have been managing this national level program office that exists pretty much to help the foundation understand the implications and ways to implement an approach to building a culture of health across the United States. So in 2015, when DASH was founded, it was in a portfolio called Data and Information, Bridging Health and Healthcare, or Data and Information System. So I'm seeing a lot of resonance in that, in the way that different people have approached this work from data sharing or social determinants of health or somewhere in between. So DASH has been running in the last, in these last years, a number of different kinds of funding programs and learning opportunities to try to understand the ways that data itself and or social determinants themselves have an impact on health equity. So we'll dig into that a little bit more later. I have I'll invite you to check out Data Across Sectors for Health at our website. We do not have as much of a Michigan presence as I wish we would have, because in many ways Michigan has itself been a leader and has had a number of interesting things going on that digs into this this potential for, or this examination of the relationship between data and health equity. And I appreciate this opportunity to discuss it with this panel and with the audience on this call. So with that, I will turn it over to Renee Smitty to introduce yourself.
Yes, thank you. So Renee Smitty, I'm the Senior Director of Policy with the Michigan Health and Hospital Association. My role here today, though, is I'm representing the HIT Commission and the Community Task Force. My interest is bringing the data points and all the different information streams in a process that practitioners can readily use it and take action, but also patients and consumers can also have transparency with their data and know how their data streams are being shared and can actually access those easily. So I'm happy to participate in the committee and talk about how data can be actionable to help address health inequalities and how we can actually include the patients and consumers in this discussion.
Great, thanks, Renee. Next up, we have Claire Tanner. Claire is the Director of Center for Data Management and Translational Research with the Michigan Public Health Institute. Claire.
Hi, thank you for inviting us. We are really excited to be here, Melissa and I. I also serve as co-director of the Data Across Sectors for Health program office, which Melissa has discussed. I've been at Michigan Public Health Institute since 1999 and worked with so many of you, recognized many of the names on the participant list, but my background is an evaluator first and foremost, and came into this as an evaluator of systems change initiatives, especially here in Michigan, including work from AHR, funded by AHRQ, about how clinical data information systems can support healthcare and clinical decision-making, including our Michigan demonstration of patient-centered medical homes, and how that was broader, how care management can impact health and healthcare. And then the Pathways to Community Hub model, supported by a grant from CMS, in which I think we're finally getting to the topic of multi-sector data exchange and information that can support community health workers in facilitating coordinated care across health and social services. And from there to the state innovation model, and now a big focus is our work on DASH.
Great, thanks so much, Claire. And last but not least is Molly Welch-Marahar. She is the manager for the Strategic Alignment and Engagement Office of Policy and Planning. Also a mouthful. Welcome, Molly.
Thanks, Lisa. And it's the Strategic Alignment and Engagement section, which is housed within the Office of Policy and Planning. Still a mouthful, but hello, everyone. Good morning. Thanks for the introduction, Lisa. My section, the Strategic Alignment and Engagement section, shepherds our state's work where it relates to health IT, and particularly at the intersection of that and social determinants of health. So my section, Teresa's a part of it. We support work on our social determinants of health strategy, as well as shepherd the work of our recently adopted 5-year health IT roadmap. And I come to this role by way of, I worked in the social services for several years before kind of pivoting to a career in policy. And I moved from social services into substance use policy. And so my expertise is really in behavioral health. So I come to this role with kind of a strong belief in the importance of peer recovery coaches and consumer mediation of access to health information, which is an essential component of SUD services. So I'm really grateful to be here. I'm really glad to have Marissa and Renee, our HIT commissioners and CIE task force members, here to talk about how this work is relevant within, their view from their organizations and their roles on those task force, as well as Teresa, who's a real asset to my team and an expert in a lot of the more granular aspects of the data components of the work. So thank you for having us, Lisa.
Thank you. So the meat and the potatoes of this is really, we want to get into not just kind of, hey, what are my thoughts, but then being able to engage with the audience, because that's where we really start to develop this. So we're going to ask a couple of questions. I'm just going to kind of go down the line, and I'm going to base it on who I see first. So the first question is really, how can shared data support health equity? And Molly, because I left off with you, I'm going to put you on the hot seat first. So if you want to start us off.
I think there are many answers to this question. But I think first and foremost, health equity has to drive the data, right? It has to drive how we structure systems, and it has to drive how we look at data, and it has to drive how we use data, and not the other way around. I think one of my recent favorite examples of how data and technology can support health equity is actually an example from my substance use policy days. At MDHHS, we developed a system called the Syringe Utilization Platform, which allowed local syringe service programs to report up data on syringe utilization. And, I love this example because it's not the platform itself that was the solution here, but really a tool to kind of better understand how we work with that population. And what we learned from the syringe utilization platform is that there's vast disparities in who's accessing syringes. And then if you extrapolate, that out, clean syringes are associated with a reduction in disease transmission, as well as a likelihood of being engaged in other services. And so seeing that racial disparity in access to these services really allowed us to allocate resources in a way that promotes health equity. And to me, that's a great example of how data can support health equity. We know that clean syringes are associated with better health outcomes, a reduction in risk of opioid overdose and other drug overdose. And we were really able to use that data in an actionable way. But it was driven by the need to provide clean syringes in vulnerable communities. So I think that's where I'll stop my answer, being cognizant of how many panelists we have and the time we have.
We do have a lot of panelists, and I'm sure each one has their own take. So I'm going to call on Renee next. Same question.
So when this question, I thought about my past life. I was a health promotion researcher with the U.S. Army Public Health Command. And this was when, I don't know if you recall, about 10 years ago, suicides were very high within the Army. And we were able to use data to track when soldiers were at most risk for suicide or negative behavior. And it wasn't actually right when they came back from a deployment. It was about 6 months later. And then we were able to track that PTSD really hit soldiers about 5 to 10 years post, that traumatic experience. And so with that information, we were able to direct resources to those soldiers who are on that Afrigen cycle in their deployment. And it was a great program. I know we all don't live in a bubble of the Army, but we were able to pull community leaders together. We had police officers, we had hospitals from outside the post. So I was in Fort Campbell, Kentucky. We were able to pull in Vanderbilt. We were able to pull in, the local community mental health facilities and kind of talk about what we were seeing on posts in the different units and direct those resources to help those soldiers. So I think that if we have the data and if we have the data of the community, if we're seeing trends, that we can really direct the resources to that. to that issue. And I think the health equity data too, I have a great friend, Shervan Essasari, who studies Black men and the discrimination that they face around mental health. And so that they normally have higher mental the depression rates than, you know, Black women or white men. And knowing that stigma, that implicit bias, I think he can go out and educate providers, but he can also educate groups of Black men to understand, like, these are the barriers that you will face. How do we empower these people and give them their own health data? Can we give patients their health data so that they can advocate for themselves and the services that they need? So that's kind of what I think in terms of health data, our health equity data, and how can we direct resources to the different communities that need them, but also how can we use that data and give that information to patients so that they can advocate for themselves.
Great. Thanks, Renee. Next up, I'm going to call on Marissa. Marissa, do you want to answer that question? How can shared data support health equity?
Yeah, I love the examples that Molly and Renee both gave. I think when I look at it, I kind of take a step back and say, what's in common here? Data is allowing us to identify a need, to help tell the story and prioritize that need to make sure that we can get the resources that we need to drive against it. It helps us to actually take the action that we need to take. So data, you know, giving data to providers, giving data to community organizations, making sure that they know who it is that needs to service us, that action can be taken. And then on the back end, data is what allows us to measure the impact. Is what we did actually having an impact on the challenge that we were trying to solve to begin with? So I kind of think of it as those three stages. One, you have to identify, and then you got to get prioritization in place. Is this the right problem? Is there enough people excited about this? Is this, you know, of all the things that we could look at, is this what we want to do? And then you have to be able to take action, and data facilitates that action. And then it also allows you to measure on the back end what it is that you did and if it was effective.
Can I just, sorry, see, I'm interrupting and everybody hates me and we all know it, it's fine. But as what we're talking about now, like what we're seeing here, this is data in aggregate, right? So this is not like what you guys have all been talking about is sort of like a lot of information about a lot of people and then taking that information and sort of synthesizing it. But that's de-identified in some ways, and in some ways it's not de-identified. I just want to make sure that like people understand, again, I'm not the most technical, but this is data in aggregate. This is what happens when you have so many people that are experiencing so many problems that you can take all of that information and measure it, right? I'm looking also, I would love to hear as we talk about data in aggregate, also like what does it mean for people to like get the information that they need when they need it? Is that, you know, I want to separate out data in aggregate, de-identified data, and personal health information, if we can. That's
yeah, and my response actually covered both of those, Joanne. I really feel like up front it's aggregate, identifying the issue, and on the back end, kind of the measurement is also an aggregate. But when you actually think about the action is at a personal level. It has to be for that person that is a part of this population that has been identified. And you're not going to be able to make an impact in the same way if you don't target that specific person. And I think in both the examples that Molly and Renee had, it gets down to that specific person when you are going to take an action and try to intervene. So I appreciate that distinction. And I really, you know, I think it has to be kind of at both levels.
Agreed. And I think that, and I'm going to interject because I think that when we start talking about that concept of data aggregation, when we're talking across sectors of care and we're talking about measuring impact, not just within, you know, healthcare that has specific payers that measure those, that level of impact, that's when we have to look at it from a slightly different lens if we're going to achieve that overall health equity outcome. I don't want to forget to call on the rest of our panelists for that same question, given what Joanne has brought to this. Claire, do you want to go next?
Sure, and I'm really glad to see the focus both on individual level data as well as population data. So back to the definition of health equity, ensuring that folks have access to the services that they need to be healthy. You can think about, making sure that individual clients and their community health workers and their case managers are able to have data so that they can communicate and coordinate care. And but ultimately, when we think about access to something like housing or food that is needed so that people can engage in their health care plan, whatever that may be, if it involves living in substandard or unsafe housing or being housing insecure or hungry, the individual data helps them advocate for the services they need. Much of what community health workers do is also advocating, and sometimes against a broken system. So it is really important to think about the aggregate data that are needed and getting that data into the hands of people who can advocate for the policy change that is needed. And we have examples of that in DASH, where state agencies have it through fiscal intermediaries so that access can be at the appropriate level and de-identified, but linked to compare outcomes and, for instance, how housing can impact health and healthcare, and use that data to actually direct policy change that gets more resources into housing. It is very hard for community health workers to get housing for a client when there are so few opportunities available in the community. I guess just a couple of other themes that I'd like to introduce, in addition to making sure there is equitable access to the data that are needed. So for instance, the folks who are going to take advantage, like coalitions and communities, somebody, I think maybe it was you, Joanne, or even Dara, who said data flow at the speed of trust. It is really important to dig a little deeper and think about what do we need in terms of the dialogue, the collaboration, and the governance structures that enable trust. And so trust not only of people and where their data are going and what they're being used for, and also trust across systems at the community level, who certainly need to coordinate to build systems that are more responsive to the needs of community. I have more, but I think I better let somebody else have a few.
I do like where you were going with that, though, because that does kind of bring up power differentials and how we have thought in this country about kind of healthcare versus the coordinating services within the community. So the power differentials that we see there, all of a sudden, those relationships that were siloed really need to be able to come together now.
And I think it's really important when we think about the engagement that is needed, is that this is a long-term process that involves multiple ways. We are investing in a lot of communities that are really thinking through non-tokenizing ways to make sure folks have power, not only a seat at the table, but a way to say, what is that table anyway? And there's no silver bullet to community engagement. In order to avoid tokenizing and to not burden people who are already burdened by being in poverty, you need to think about multiple ways to repeatedly engage, to make sure data are bidirectional, not to rely on a single individual to represent an entire class of people. So there's a lot of work nationally going on around that as well.
Agreed. Teresa, I know that you've got some thoughts.
I knew you'd call on me right after Claire, because Claire said everything that I was thinking.
Never.
But spoke it so well. so just to kind of add to that too, I really agree with that, not having one person represent this entire group of folks and to meet people where they're at, right? And so just everybody had such great examples, and just to the only thing I can think to add to this that I have a passion for is rural health. And one of the things that I think I'm most excited about for the state is our new MiHIN office. And what kind of goes in line with our HIT roadmap is expanding that broadband to all areas of the state, and not just expanding the broadband, but enhancing the level. So bringing part of the health equity piece is making sure that, yes, everyone has access to the data. They can input that data, but also where's that data coming from? And if it's generated by the person themselves, that they're inputting that data themselves, they're the source of that data, they need to have access to that basic infrastructure to allow them to do that. So that's one of the things I just wanted to add. And then along with the rural health piece, Claire touched on the housing and the food, and also transportation in a lot of areas, just understanding the lack of access to transportation and how it does vary from region by region by region. So to add to that other piece of the equity though is also, and relates back to the broadband and the efforts in the state, is virtual care and telehealth and remote patient monitoring, which also touches on the rural piece, but also in different pockets and other areas where people don't have access to that healthcare or transportation. And I'm just enjoying sitting back and listening to everybody else. So I'm going to mute again and, and go back to that.
No worries. No worries. Thank
So
you.
we have some engagement from the audience. I just want to give people their, like, come be with us. Chrissy,
Yes.
Tell me what you mean about trust and your clients, and tell me where you're coming from.
Yeah, I think I come from, I work at Jewish Family Services here in Ann Arbor. And I think it's, when I think about technology and I think about that final mile of like, okay, we have the system, we enter it in, like the agency receives it, the client gets the help. And I think that to me, like when I think about technology and I think about that trust, is like, it's hearing the clients, it's hearing what they want and having like valid and solutions to their concerns, so that they learn that I hear you and you can trust me to be your partner in finding solutions. And I think that if technology can support that, and it doesn't overly burden the agency and it doesn't overly burden the client, it can be very successful. I think the issue can sometimes be in that overburden.
Boy, would I agree with you on that front. I'm gonna try to engage Melissa Moorhead to see if maybe she can kind of wrap her answer into kind of your answer. I'm gonna challenge it.
That is a challenge, although one that I think that I struggle with all the time, and that is the that individual impact and the way that we understand equity at the individual level, and how we would promote equity by the aggregation of individual outcomes and access to data. Thank you, Claire, for that. A lot of different threads there. I have been very interested in how shared data can support health equity at a different level. So away from the aggregation of individual level data and the attention to equity at that individual outcome level, and more perhaps at a structural or policy level where you can take a different kind of data. You can take that outcome data and look at the ways that policies have created stigma or barriers to equity, and I mean, I guess maybe it needs that urgency of this is the impact on people's lives is real, and that what the opportunity to using shared data to support health equity initiatives at that structural level intervention is to say, well, from my own personal experience in HIV prevention and case management, testing is a public health intervention. Equity shows up in all kinds of ways in the individual level outcomes, but at that structural level, if it is important to public health that we understand a disease and disease burden in a community, but at the same time, we don't do anything to address the impact on individuals of the stigma about that disease in the community, we're not really addressing a social determinant of getting people access to the care they need, getting people involved in that work, and you know, the COVID pandemic has also made those same parallels between ACT UP and like making public health a political movement, because there is this more structural level of shared data or aggregate data at that structural level intervention that's important to achieving both better outcomes at the individual level and sustaining them at the population health level.
I wonder if I could comment on that quickly.
Ryan, hi.
Hello.
Where are you from?
Well, I live in Colorado, but most of the work, so I'm a consultant. My firm is based out of Berkeley, California. And a lot of the things I do is actually interviews with community-based organizations, predominantly on the West Coast. But I thought it was interesting bringing up the structural component, because that is something I was going to bring up as a question too, is I think we sometimes attack health equity in the middle. And by what I mean is we're looking at what data we have, but it's kind of working with a very partial data set. When you think about, when I talk to some of these organizations, they wouldn't put their race down on a resume. They wouldn't put their race down on a college application. Why would they do that for any kind of medical intake? And so I think there is some messaging there about that data entry, that front end of how you collect that data better. And there's a few different pilots going on in Santa Cruz, for instance, that we're trying to figure out how we can improve that data set. But yeah, I'd just like to toss that out there as something that I think one of the things we've been finding that's a very unique relationship is a lot of HIEs tend to have a lot of health information, but a lot of community-based organizations have more trust with their clients and tend to have more accurate race and ethnicity data. And so sharing that, essentially having almost like this up convert process of where you have an unknown or you have a very, unreliable data set from an HIE as far as some of those health equity factors, and you combine it with community organizations that work with individuals on a daily basis, you have a kind of a better source of truth for some of that health equity data to be kind of merged with some of those more health information exchange data. So.
Very much agreed on that. And I don't even think that we necessarily 100% understand what data is going to be critically impactful at this point in the game. So I've heard a lot of different themes in here, but kind of the overarching theme of that question was, how can data support health equity? That data drives decision-making in the long run, decision-making about where to spend scarce resources. Let's face it, there's only one pot of money. And we have to figure out both from an organizational level and from a societal level where that money is best invested. But that can seem like a big chunk. That can seem like a massive problem. What, in your opinions, are the steps that need to be done? What do we have to do to make that data exchange more supportive of healthcare? How do we get there?
We have 10 minutes left. So
Yes.
This question is going to go to each of the panelists, and you will say like what you're doing. This is what you guys do. This is how you spend your really good time. What can we do to make data and the exchange of data and the sharing of data more supportive of health equity? How are you tackling it?
So these are going to be quick answers because we still want to take more questions. Melissa, I'm going to start with you because you had to go last time.
I was afraid of that. So more supportive of health equity. What can be done near term? So one of the things I think is always helpful, and both near term and continuing to return to it over time, is this level setting, right? Because Lisa, you summed it up quite nicely in terms of all this discussion shows up in a really concrete kind of way when it comes to paying for some kind of activity. And the thing that we're trying to get at is how best to use this scarce money resource to support healthcare. And I think that's great. And there's all kinds of work to be done there. There's work to be done in different levels of this, of our sort of community and social engagement. And to the extent to which data can help us be much more mindful of where we are right now, the things that we are actually addressing right here, and the impact that we can make right here. It's an ongoing way to use what's available, I think, to be supportive of health equity, because we're really digging into what's possible and available right now. But ask me next week and hopefully I'll have a much better answer.
You're on mute.
Yeah, Renee, go for it.
Oh, I really focus on the policy perspective. A lot of organizations, national at the state, are doing a lot of great work in this space, and how do we get into a better spot? But because there's so many groups working on this, there's a lot of folks who are kind of waiting on the sidelines to see which spaghetti sticks to the wall. So I think trying to coordinate and get us all on the same true north is really important. And what policies are we going to implement? Because nobody wants an organization to waste money and have to do rework. So that's really what I'm focusing on day to day.
Agreed. Teresa, how about you?
Sure, I totally agree with Renee. Everyone's kind of, I think back to the EHR implementation days when there were very clear requirements from CMS that you have to collect this data, and this data, and now not so much, right? So I think just to be very, short with this answer, because there's so much that goes into it, is transparency. What are we actually looking at? What work is actually happening now? Who's collecting what? What's the source of the data? Is it self-reported? Like as Brian mentioned, a lot of if the option to self-report and put your own information in is available, what help is available for those to understand why that data is important, to be transparent with it. And then inclusion. Not just making the assumption that these are the standards that we're going to use and we don't need to hear from anyone else about it, but inclusion of all the stakeholders and of course, shared standards, and having that, I guess, I hate to say the C word, conformance, but have that built around it as well, I think is important to make that more supportive of health equity.
Great. Keeping us rolling. How about Claire? Thoughts?
Sure. Well, I guess I was going to say, try to sum up by introducing one new concept, and that is do no harm. I think well-intentioned sharing or exchange or aggregation of data can do harm. It can do harm because data have biases, and to the extent we are basing our algorithms on who has accessed services in the past. I just saw a presentation from a vendor touting an engagement algorithm that could predict who will engage with your care managers, and alarms were going off in my head about you're basing that on who's accessed and engaged with services in the past, which we already know is leading to inequity. That's sort of the purpose of this panel. But second, narrative matters. And a lot of the screening tools and other information that we're seeing collected on social needs is very deficit-based, and it trains the eye towards individual or differences that individuals make, and doesn't necessarily lead to the structural solutions that folks were talking about. So does it train your eye to say, oh, this group tends to make poor decisions regarding food choices, or does it train the eye to point out what food entire populations have access to? So I think, as we think about data in this space, it's really important to think about the data that can identify the structural or the systemic causes for the patterns that we see. And then, so that really gets back to the engagement. If people who are experiencing these issues and are closest to the problems are engaged in finding solutions, they point out these problems with the data painting a negative picture of them and their community, or they point out to the measures that actually matter to them. So back to engagement, early, often, systematically. Just finally, qualitative data. It's really hard to interpret data without stories, and those stories need to come authentically from the people living them. And that can really elucidate some of the structural reasons for the patterns that we see.
Great, thanks. We have 3 minutes left, so I'm gonna let Molly go next.
Thanks, and I'll try to keep it brief, but I think one of the things that we're grappling with right now, actually, in the department is how to make our data more reflective of the communities about whom we're collecting it. And to me, it really boils down to inclusive processes for data collection, planning, implementation. It boils down to representation. I was reflecting on, I'm with a bunch of smart people right now, but we're all white women. And what implications do that have for what we're doing? So I think it boils down to participatory processes, active identification of where we need more representation, and proactively making sure that we have that representation. For example, I think there's a lot. SOGI, so sexual orientation, gender identity expression data, is a great example of where our data is failing us and where we need some participatory processes in thinking about how we're collecting it, what we're doing with that information, what's the source of truth, and how does that look over time, for example. So that is my thoughts.
Very much agreed. Very much agreed. Marissa, do you want to wrap us up?
Yeah, I think everybody has some phenomenal points. I agree with all of you. I want to add one more thing, which is as we think about trying to take action and the people that we need to have in this system, right? We're embedding these community organizations into an existing somewhat structure around communication around health. And I think that's going to take some time. There's going to be a lot of challenges there, and making sure that we're onboarding, that we're providing resources, that we've got the data that's consistent enough for us to be able to use it and compare it, and to make sure that we've got those pieces. And so having those voices at the table, incredibly important, but also thinking about the types of support that are going to be needed to be able to address it. Going on to EMR, right, was a tremendous lift for most provider organizations. And I think that same type of thing, we have to think about that massive transition for our community organizations as well.
Agreed. And I don't want to kind of delay things, but I also do want to say that we are at time. And thank you all for being able to join. Thank you to our panelists for your knowledge, for your expertise, for your time. Joanne, I'm going to let you wrap things up because you have your own kind of.
Yeah, no, I mean, most important, look, there's like information, there's sharing information. There's also like yentas, right? Like I've got a big mouth. Tell me what you want people to know. I bother people all the time. use your people, tell them what you need, be a part of the process. Thanks for showing up. You come to these downloads, and these people are working overtime all the time on behalf of the good of the people. So thank you. More to come. I will be sending out this recording. I will be sending out these slides, and I just appreciate you showing up. Our next download is November 16th, followed by a Bits and Bytes, which is more like technological. That's more tech stuff for those people that like that better. I don't know why, but thank you. Thanks a lot.